about this. If you have doubt about identifying a normal sinus rhythm, ask me, because it's important that you be able to, from the Nclex, to either identify normal sinus rhythm. There are many, many, many questions where what they present to you is a normal sinus rhythm strip, and you simply need to identify that this is normal. What you do, nothing, just continue observation. Then you have the second strip. The second strip has no P wave. You don't see P waves. Instead, you see a vibration in the baseline. The QRS are narrow, okay? You can stick your finger with the QRS, but what calls the attention is that the distance between the QRS is very variable. This is the main characteristic that can help us identifying a atrial fibrillation. The irregularity between the distances that separates one QRS from the next. So notice that this distance is huge, this is medium, this is very small, it's very variable. It's irregular distance. And it is a characteristic of atrial fibrillation. Atrial fibrillation, being atrial, being supraventricular, has narrow QRS. So probably the answer of these questions that is asking which one is an atrial fibrillation is B. The third is a rhythm that has P wave, so has P wave. So we see P QRS, P QRS, P QRS. So until here is a rhythm that looks like sinus rhythm. But then we have one P wave, because this is small wave, is a small P wave, is a P wave, but this P wave has not QRS after it. So what means this? That the electricity that was generated in the atrium, producing the P wave that we are seeing there, could not pass to the ventricle. And it means there is a blockage. There is somebody has the microphone opened and I'm hearing myself. Okay, so we have here a blockage or interruption between the atrium and the ventricle. We call that atrial AV ventricular block. So this is not an atrial. The QRS looks normal, but then bizarre QRS complex that so it's before time, so it's premature, the same as the babies that come before time is premature, no? And it's wide, so we should know that ventricular rhythm tends to have a very wide QRS, and this is wide, is much wider than the normal QRS, as you notice when you compare. So we suspect that this is ventricular, and because it's premature, because it's coming before times, okay, it's very near, very together with the previous QRS, we call that premature ventricular contraction. So this is a PVC, premature ventricular contraction. It's not an atrial fibrillation. So everybody agrees that this is an atrial fibrillation. Any doubt about that? Silence. Okay. Let me ask you something. If this patient is an atrial fibrillation, which medications, and it's a chronic atrial fibrillation, which medication you anticipate the doctor is going to prescribe? Who can open the microphone and say that? Which medication you expect in this client?
Amiodarone.
Amiodarone with the purpose of what? Okay, let me walk over amiodarone. Okay, so let me talk about amiodarone. Amiodarone is correct. It's not incorrect. Amiodarone. Which purpose do you anticipate doctor is giving the amiodarone? Tell me. Don't be shy.
To calm down the heart.
To calm down the heart, no. To calm down the heart, it means to decrease heart rate. Usually, atrial fibrillation is very fast. So the person has more than 100 beats per minute, sometimes at 150, 160. And it is a tachycardia. And the heart needs to be calmed down, decreasing the heart rate. For this purpose, we use medication called chronotropic negative. This has been tested in Nclex. If you understand the concept of chronotropic negative is a medication that slows down the heart. More than calm down the heart is to slow down the heart. And the main chronotropic negatives are the beta blockers. Let's see, metoprolol. Okay, metoprolol is the classical beta blocker, no, that ends in LOL. And the calcium channel blockers, okay, that includes the diltiazem and the verapamil. So those are the medication, verapamil, intended to slow down the heart. And yes, can be also being used in the doctor decides to use amiodarone is for something more than calming down the heart, to more than slowing down the heart rate, is to convert this atrial fibrillation back into a normal sinus rhythm. So remember that we have two situations in atrial fibrillation. One is the patient has an acute AFib, that is possible to be returned back to normal sinus rhythm and point, final point, nothing else. Yes, it is a doctor decision. And if this acute atrial fibrillation is going to be cardioverted back into normal sinus rhythm, has two possibilities, the doctor. Electrical cardioversion, which is synchronized. You remember synchronize, okay? Synchronize, yes. Or the other option is a chemical. Okay, it's a chemical cardioversion, okay? Chemical, no electrical cardioversion, chemical cardioversion. And the chemical cardioversion is done with amiodarone. So if you have in Nclex a question of a client with an atrial fibrillation, and they suggest that the client is going to be treated to eliminate the atrial fibrillation, the medication that could be used is the one that the student mentioned, amiodarone. Amiodarone is a medication to remember that can be used to convert atrial fibrillation back in a normal sinus rhythm. This can be also obtained with electrical cardioversion. What is the only thing that we need to remember from this electrical shock, this electrical cardioversion, that is synchronized? It means in the machine, there is a button that says sync, and it needs to be pushed. As I explained in my classes, for the my classes, it's important that this electrical shock is coincident with the QRS, or the absolute refractory period, because if the electrical shock is delivered during the relative, the area of the T or the ST segment, a worst rhythm can be, produced. Ventricular fibrillation. So it's very important that when there is a supraventricular or atrial dysrhythmia, a dysrhythmia that is originated in the atriums, not in the ventricle, what is used is electrical cardioversion. That means that needs to be synchronized. Okay. By the contrary, the electrical shock in ventricular dysrhythmia, specifically ventricular fibrillation and ventricular tachycardia, unstable ventricular tachycardia, is asynchronic and is not called cardioversion. It's called defibrillation. So the electrical shock can be cardioversion when it's synchronized and is reserved for the atrial or supraventricular rhythm, especially fast rhythm, like supraventricular tachycardia, atrial fibrillation, and atrial flutter. So which one are the three supraventricular rhythm that we most know well? The atrial fibrillation that we're discussing here, the atrial flutter that is for practical purpose practically the same, the supraventricular tachycardia. Yes, we know. Okay, this is cardioversion synchronized. The defibrillation for ventricular dysrhythmias, that is asynchronic, no synchronization needed, and is used in ventricular fibrillation and ventricular tachycardia, clarifying concept. But in the case of atrial fibrillation, yes, it's true. Amiodarone can be used, but only if the doctor plans to return the client from normal sinus rhythm, from atrial fibrillation, sorry, to back to normal sinus rhythms. A question for the person who said amiodarone. Do you remember the test that is mandatory, because it's another Nclex question, a test that is mandatory before returning the client in AFib back to normal sinus rhythm? Which test is that? Who remembers? Huh? Do you remember that patients with atrial fibrillation could have clots in the atrium? And if the doctor makes the atriums contract again because the patient is returned to a normal standard rate. Say again?
Echocardiogram.
Echocardiogram, but can be echocardiogram being seen, the atriums are seen through the transthoracic. Esophageal, transesophageal. They need to introduce an endoscope in the esophagus, and the endoscope has the probe to see the atrium through a transesophageal echocardiogram. This is an Nclex question. Which test is required before converting a atrial fibrillation back into a normal sinus rhythm? Okay, so need to be done through the esophagus, because through the thoracic chest, the atriums cannot be seen very well, are much, much better seen through the esophagus. So now I can imagine which other question could be in Nclex of this scenario. The patient for a TEE or trans-T esophageal E echocardiogram, yes, need to be MPO, is invasive, needs consent, need to be MPO. The patient is going to be sedated, and the patient is going to have local anesthesia with benzocaine in the throat, so the gag reflex is going to be blocked. And it's our responsibility after a TEE to check the return of the gag reflex before allowing the client to drink or to eat. Can you add this and connect these two concepts in one? Now you are connecting cardiovascular with GI. We're studying cardiovascular in GI. You understand me? Okay. If you have doubt, if you don't understand my explanation, interrupt me and ask me again. So I agree with you. Amiodarone could be used, but it is generally used in the acute atrial fibrillation. Yeah. If the client is not having acute atrial fibrillation, the client is having, let's see, a chronic atrial fibrillation. Okay, so it's a chronic AFib. Okay, a chronic AFib is a person that has a heart already damaged by hypertension, ischemic heart disease, is too enlarged, and as a consequence of this enlargement is an atrial fibrillation. And there is no possibility of returning this client back into normal sinus rhythm because it's not obtainable, it's not attainable, it cannot be maintained. So this person needs to live the rest of his or her life with the atrial fibrillation. Do you understand me? So now is when the doctor is going to be using this medication, this metoprolol, or the diltiazem, for the purpose that you mentioned, the other student mentioned, to calm down the heart, to slow down the heart rate. Why? Because it's living with the atrial fibrillation, but not so fast. Now it's an atrial fibrillation of 80, 90 beats per minute. Why? Because it's taking every day metoprolol or diltiazem for the rest of the life. What is the other medication?
Digoxin.
No, well, it's true. Sorry, you're right. The person who said dioxin is correct. Dioxin can be used to slow down the heart. Remember that dioxin slows down the heart. And dioxin is a chronotropic negative. That's why you need to check the apical pulse before each dose of dioxin, because it is below 60, you cannot give it. It's too much dioxin, it's intoxicating, yes? So yes, you are right, dioxin can be used. The problem is dioxin is not used too much now. You know why? Because dioxin is too toxic. Being metoprolol or diltiazem less toxic, less risky. Doctors rarely now they prescribe dioxin, just for your information. But you are right, dioxin can be used, but with the purpose of slowing down the heart, to calm down the heart. So I could add here in the chronotropic negative medication and dioxin. Okay, so you are right, dioxin. See, dioxin. But the medication that I wanted to
Adenosine.
no,
Beta
you're wrong.
blockers.
This, la pata. This is not correct. Adenosine is for supraventricular tachycardia. Metan la pata. Commit the
Warfarin.
mistake here. Commit the mistake
Warfarin.
here.
Dabigatran.
Beta blockers, Professor.
No.
Dabigatran.
A beta blocker is a LOL. We already mentioned beta blocker, okay? We already mentioned the chronotropic negative, beta blockers, calcium channel blocker, dioxin. But now somebody mentioned adenosine. Yes. Let me wait. Let's fix this misconception, this error. That maybe is the error of one more than one student. What you say, adenosine. Adenosine is a medication. Me faltó la E. Is a medication that is used only for supraventricular tachycardia. Only for this. This is the medication that can stop the heart for seconds and can revert a supraventricular tachycardia. Supraventricular tachycardia is different from atrial fibrillation. Supraventricular tachycardia looks like a normal sinus rhythm, but very fast. I mean, the QRS are so near one from the other that you say, it's tachycardia. Somebody has opened the microphone and hearing myself. And this is different. I don't have any picture here of the supraventricular tachycardia, but adenosine is only for supraventricular tachycardia. So correct this misconception, okay? The other medication in chronic atrial fibrillation are part of the chronotropic negative, as most of you said, is an anticoagulant. Both medications are usually given to clients with chronic atrial fibrillation. So you have two scenarios: the acute atrial fibrillation, where amiodarone is used, yes, or cardioversion is used, yes, as far the client has a TEE, transesophageal echocardiogram, that rule out the presence of clots in the atrium, preventing the drama, the catastrophe of pumping the clot to the brain if the rhythm is returned to normal. But you have in the other side, the chronic atrial fibrillation, hundreds of people that are living the rest of their life with atrial fibrillation, but they need to take two medications, one to slow down the heart and one as anticoagulant. Why anticoagulant? Because atrial fibrillation forms clots in the atriums that can be pumped to the brain, producing a stroke. So if you have another question in English, which cardiac dysrhythmia is associated with a stroke, you say atrial fibrillation. How we prevent strokes in patients that suffer of chronic atrial fibrillation, giving every day for the rest of their life anticoagulant, oral anticoagulant. Is clear? Is clear? Everybody understood that? And adenosine is not used for atrial fibrillation. Okay, so have those concepts very clear because our everything that had to do with atrial fibrillation. Atrial fibrillation is the most common dysrhythmia tested in Nclex because it's the most common dysrhythmia that you are going to see in your practice. And all those concepts are very important, very important. By the way, a client with chronic atrial fibrillation taking metoprolol and taking Coumadin, warfarin, is a stable client. I'm repeating, pay attention, you, that you are distracted. Turn off this phone, caramba. Okay, atrial fibrillation, chronic atrial fibrillation, yeah, that a client that is already in control with a chronotropic negative medication, so metoprolol, diltiazem, or digoxin, plus an anticoagulant is a stable client. So this is a client that can be delegated to whom? To the CNA, to the LPN, or to the new graduate nurse, or the nurse that is floating from OB, mental health, etc. They don't know too much about that. Why? Because the only thing that need to be given is a tablet of metoprolol and a tablet of digoxin, and it's a stable client. Another Nclex question, where you have 4 clients with different dysrhythmias or cardiac problems, and they ask you which one you can delegate to the LPN, which one you can delegate to the nurse that is floating from OB, that they don't know anything about, cardiac dysrhythmia. A patient with chronic atrial fibrillation in control with beta blockers and anticoagulant is a stable client. Okay, those are the topics that I remember have been present in Nclex about atrial fibrillation. As I said, it's very common. It's very, very common, and that's it. It's something that you should know. Any question, any doubt is left about atrial fibrillation? Nobody have a question? Can we move?
Thank you.
Okay.
Yes.
So please have very well clear your knowledge about atrial fibrillation and those topics that we commented, because I can assure are repetitive and common topic and many, many different questions, but the concepts are the same. Okay, so let's move to other. I wanted to start today with some EKGs. Okay, the client. It says the client is okay. I need to move this question down so you see the 4. Just a moment. Okay, the client is taking torsemide IV and presents a common side effect of this drug. Okay, which EKG correlate with this scenario. So the first that we need to do if we have this question in Nclex is asking ourselves, do I know what torsemide is? What sounds like torsemide?
Diuretics.
Yeah.
Furosemide.
Bumetanide, which is a loop diuretic, the potent one, no? And they are talking about a common side effects of this drug. What are the common side effects of giving this family of diuretics?
Hypokalemia.
Hypokalemia. Questions about that. But don't forget that you have also hyponatremia, low sodium, hypochloremia, low chloride, and you have possibility of dehydration because you have diuresis. It is more than, in this case, we don't use the term polyuria because it's on purpose. It's a diuresis. Polyuria is used more when it is a pathological condition like diabetes or diabetes insipidus. But at the end, it's the same. But just to tell you why they use sometimes this term and the other term. It's not important for the question, but it's important. So probably of those alterations, which one is classically reflected in the EKG? potassium. Okay, so we expect what? Low or high potassium?
Low.
Low potassium.
What is the finding in low potassium? Who remember?
U waves and ST
U waves.
depression.
Yeah, and in high potassium?
Peak T waves.
Peak T wave.
T wave.
And peak T wave. Yes. Okay, so okay. So if we see here, okay, this is the T wave, no? You see that is very tall and peak. Huh? This is what they mean, tall and peaked, okay? Let me write peaked, okay? Peaked, okay? Tall and peaked. This is what is a tall and peak T wave. So this is high potassium. This is high potassium. So this is not the EKG. What we see here, an EKG with atrial fibrillation. You see, it is another atrial fibrillation. How I know there is an atrial fibrillation? Because the irregular distance between the QRS, what we mentioned before. So it is an AFib. It is nothing of alteration of the U wave. Yes, so it is not. It is a distraction. Okay. Let me see D, because the answer is C. Let me see D. What you see in D that calls your attention? What you see in D, as in David, that calls your attention? I see P, I see QRS and T. P, QRS and T. What you see there that calls your attention?
That's
The
a
spike of the
pacemaker, right?
pacemaker.
It is spike. You see this line? This line obviously is artificial. And notice that it's before each one of the P and the complex. So something artificial, I mean, a machine is generating this electrical spike, producing the current. This is what we see in a pacemaker. A pacemaker is characterized by the presence of this spike. So if you never seen before, never noticed before a spike of the pacemaker, this is the way that it looks like. It's a line that you realize, oh, this is artificial. And it's before each complex, so it's what is generating the complex. So it's a pacemaker. Pacemaker has nothing to do. So what we have here, I have here the P. I have here the QRS. I have here the T wave. And in the alpha order, P, Q, R, S, T, what the letters come now?
U.
So this is the U wave. Okay, this is the U wave. Okay, so I thought before that in Nclex never presented EKGs with U wave. They asked that only with words, but now a student told me, no, professor, you are wrong. There are, okay, ¿cómo se llama? EKGs with U wave, because I had this question. I had 4 EKGs. I needed to identify the EKG with the U wave. P, Q, R, S, T are the normal wave. If an added new wave is added, need to be in the same alpha order, is the U wave. Is seen when the potassium is low, and is a positive wave that is observed after the T of the complex. No problem, yes? Okay, perfect, that's it. Any question about this? Because it has nothing else to. Which toxicity has loop diuretics, a part of hypokalemia and electrolytes alterations and dehydration, that need to be taken in consideration for Nclex? Who knows?
Ototoxicity.
Please remember that loop diuretics are ototoxic. And of course, in the Nclex, the questions that talk about the ototoxicity concern in clients receiving loop diuretic, the client doesn't tell the nurse, I think that I have ototoxicity, because they don't know what is ototoxicity. The scenario is going to be a client that is receiving high doses of furosemide, bumetanide, torsemide, and then when you talk to the client doesn't answer, doesn't react, doesn't understand, or ask you to repeat. Yes? or is complaining of vertigo. Remember that ototoxicity also can produce vertigo. So please be aware that ototoxicity is a a toxic effect of the loop diuretics, and it's very important. This is another question in Nclex, is when the doctor orders IV furosemide or in which how is administered the IV push of furosemide? And the answer is slow in at least 2 minutes, because the ototoxicity occurs when it's administered too fast in emergencies like pulmonary edema, etc., in which the furosemide is given and the patient critically ill. If it is given too fast, then the concentration elevates in blood too fast, and this is the peak, is what produces the ototoxicity. So it is another topic that I've seen about this ototoxicity. Don't forget that other medications are ototoxic. Don't forget that aspirin is ototoxic. Don't forget that aminoglycosides, gentamicin, kanamycin, streptomycin, and the vancomycin are also ototoxic, okay? It's more difficult to remember, but this is a medication for cancer that is frequently used. Is called cisplatin. Cisplatin, okay? Must be expensive, no? Cisplatin, no? Cisplatin, okay? Cisplatin is also very ototoxic, okay? And need to be known. Trying to remember all the toxicities of the medication together. Which medications are hepatotoxic, which medications are ototoxic, which medications are nephrotoxic, because it's a way that we remember that it's frequently tested toxicity. Okay, so no problem with this question. We are competent with this. Okay. Okay, so let's move this question down so I can present that. I can't increase a little the size. Which of the following drugs the nurse expects to be okay, the question starts here. It is a question that we already can answer based in our previous discussion. Yeah, another way of presenting the topic. The nurse observes the sudden beginning of the following rhythm in the client's monitor, and you see this rhythm. Of course, with the rhythm, you identify, oh, it is supraventricular, it's atrial because it has narrow QRS, but has no P wave, irregular baseline, and the RR distances are irregular. This is an atrial fibrillation. What means sudden? Acute. Yeah, acute. Sudden beginning of the following rhythm the client's monitor. So it's an acute atrial fibrillation. And now the question is, which of the following drugs the nurse expects to be administered to return the client to normal sinus rhythm? Warfarin, metoprolol, amiodarone, dioxin. Which one?
Sí.
Amiodarone.
We already discussed. We already discussed here, and if we were paying attention, that we had two situations: acute atrial fibrillation and chronic atrial fibrillation. In the acute atrial fibrillation, it's common that doctors want to return back the client to normal sinus rhythm. For this purpose, they use a medication or an electrical cardioversion. Electrical cardioversion, we already mentioned how it is done, synchronized, and the medication was amiodarone to return the client to normal sinus rhythm. But there are clients that cannot return to the normal sinus rhythm because they are too sick. And they need to live the rest of their life with chronic atrial fibrillation. To have those clients stable and asymptomatic, those clients are receiving two medications, beta blockers and calcium channel blocker, beta blocker, dioxin, and an anticoagulant. Yes? So here, the scenario is the scenario of the acute atrial fibrillation. The patient is a sudden beginning. What means sudden beginning is acute. And the question says, which of the following drugs the nurse expects to be administered to return the client to normal sinus rhythm? Is written, is explained there. So it is not the case of the patient that needs to live the rest of his or her life with atrial fibrillation, taking a chronotropic medication and anticoagulant. It's a patient that is going to return to normal sinus rhythm. Warfarin anticoagulant and metoprolol and dioxin are for chronic atrial fibrillations. The one that is used for the chemical cardioversion and return the client to a normal sinus rhythm is the amiodarone. Do you need me to explain that again? That there are two types of atrial fibrillation, acute and chronic. And the acute, usually, doctors decide to return back to normal sinus rhythm with chemical or electrical cardioversion. And the electrical cardioversion is electrical cardioversion synchronized, and the chemical is amiodarone. Point apart. They are clients with very sick hearts that cannot return back to a normal sinus rhythm. And they are going to live, you know what means live the rest of their life in atrial fibrillation. So are going to be in atrial fibrillation the rest of their life. But to avoid the complication of having a chronic, lifelong atrial fibrillation, they are going to receive two tablets, two medication. One tablet of a medication that can be metoprolol, beta blocker. Metoprolol is a beta blocker. Can be, professor, can be atenolol, yes, can be atenolol. Professor, could be nadolol, yes, can be nadolol. Professor, can be propranolol, yes, can be propranolol. So a beta blocker, the most commonly used, metoprolol, okay? Or can be a calcium channel blocker, diltiazem, verapamil, or can be dioxin. Any of them is for one purpose only, to slow down the heart. What one student say, calm down the heart. Do you understand that? But needs a part of that another medication. For what? To prevent in this chronic, lifelong atrial fibrillation formation of clots in the atrium that could be pumped to the brain producing stroke. Can you get that? So this is the treatment of the chronic atrial fibrillation. Warfarin, metoprolol, dioxin are for chronic atrial fibrillation, for the patient that is living the rest of his or her life in atrial fibrillation. For the case that the atrial fibrillation, the doctors decide to return back to normal sinus rhythm, you anticipate chemical or electrical cardioversion. And the chemical cardioversion is the amiodarone. And you need to have those medications available, prepared, because you have the knowledge to work in team with the doctor, and you can anticipate that the doctor will need the amiodarone. And then when the doctor requests the amiodarone, you wait for me, because let me check what is amiodarone, but you don't even remember what is amiodarone. So we need to work in team with the doctors. And this minimum knowledge of the most common dysrhythmia need to be known and is tested in Nclex. Why? Because atrial fibrillation is the most common dysrhythmia that you're going to be facing in the practice of nursing. And you need to learn that very well. If you were my student, you have a PowerPoint that explains that very well. You have excellent books that explain that. And in this moment, I'm explaining that very well. Make an effort to concentrate, listen, don't write. This is not the moment of taking notes. It is not a lecture. It is discussion. I just guiding you and refreshing your knowledge, but this is the moment of placing this knowledge in the brain, because in the test, you cannot take out those notes. You cannot postpone the learning. Today, tonight, you need to live this meeting knowing atrial fibrillation, period. This is the way of studying. Stop postponing the learning, as you have been always doing. I've been fighting with you, arguing with you a lot since the beginning that you postergate the learning. This is no more time to postergate. This is the moment of learning. Now, you need to live this meeting understanding atrial fibrillation. So you need to concentrate and you need to pay attention and try to listen to my explanation. Even if I talk too much, you need to pay attention to me talk, because the purpose is talk. If you learn and you live this meeting knowing atrial fibrillation on whatever we are discussing here. You understand? Okay.
Yes.
Ale salió su regaño. You already, you cannot leave my meeting without being scolded. Okay. So everybody agree that it is another way of asking the same that what we discussed, okay, what we discussed. And notice how you apply the knowledge of the previous question to this question, okay? Go ahead. The next question. The next question starts here, okay? The nurse observes the following image. Another example that is going to help you. The following image in the cardiac monitor of a client with pacemaker. Remember that those questions that are built by me, I find, copy and paste the image, etc., from internet, but are related to situations that have been anchored, that brought difficulties to the student that commented that to me. Okay, so the nurse observed this EKG trace. And notice that something is wrong here. After notifying the provider, how the nurse documents this finding. And the options are premature supraventricular contractions, second-degree AV block, pacemaker capture failure, and asystole. Those are the first options. So let's see what, if I had this question and I'm not very sure of the answer in Nclex, what I could be doing. Let me see. Which one of these options here I can rule out? Asystole. Any person that knows what is asystole should know that it's a flat line. Even my neighbor, which is an old lady, knows what is a flat line, no? Because in the movies and the TV is always, you know, at the ends of the tragic or dramatic movie or whatever, there is a flat line. So flat line is this stuff that you see here. Is aligned with that. So this is not a flat line. So now I have three options because I could rule out this option. So it is an important strategy that you can start, you know, eliminating to increase the possibility of answering this question correctly. So let's see what we have here. Pacemaker capture failure, second-degree AV block, and premature supraventricular contraction. Okay, so we don't see here P wave. P wave, when are seen, and there is a failure of the P wave to produce and QRS, could be used to diagnose for first time before a pacemaker is implanted, to diagnose AV block, okay? You cannot diagnose here an AV block if we don't see P wave. So this is not a second degree AV block, because to see an AV block, I need to see what I showed you before. I see a P wave, and I see after the P wave a QRS, yes? But then I see a new, again, P wave, but then I don't see QRS after this P wave. What means this? The electricity in the atrium could not pass to the ventricle, and it is an atrial ventricular block. It is difficult, or you need more picture, okay? Remember that the heart has the atriums and the ventricles, and the electricity is originated in the atriums and need to pass to the ventricles. Yes, here there's something called AV node that, you know, that delays the passage. Frequently, people, for different reasons, but mainly because aging, these AV nodes develop a blockage, you know, and then the electricity that should be passing to the ventricle to produce the QRS is not passing. How you recognize that? Because the electricity is yes in the atrium, you see P wave. But then when you should see a QRS, you don't see the QRS. Sometimes it's pass, sometimes it doesn't pass. When it doesn't pass, no QRS. When it passes, yes, QRS, you know? So, but just once that the electricity cannot pass to the ventricle, you say, oh, it looks like it is a blockage, okay? It's an AV blockage, okay? So it is a way of ruling out this option. So I can rule out this. To see premature supraventricular contractions, okay, this is something new. We never talk about premature supraventricular contraction. We talk about ventricular, not supraventricular. Yes, it can be, but those are you know, QRS that occurs before time. So if I have here a QRS and now I have a QRS, same as the before, narrow, okay? But premature, that doesn't look. So they are talking about pacemaker, and I heard, and at least if I never heard that before, I heard that when there is a pacemaker, there is a spike, which is like a line, artificial line, that is no more than the electricity generated by the pacemaker. You know, the pacemaker is an artificial generator with a battery that has a cable that goes through the veins and enters inside the right heart through the superior vena cava, right atrium, and right ventricle, and can send the electricity directly to the heart. This electricity is seen like a line called spike, and we are seeing here spikes. So this must be a pacemaker, and the only option here that is talking about pacemaker is option C. So now, even without never seen before a pacemaker failure previously, we know that it is a pacemaker, and any of the other option is about pacemaker. So the answer must be C. So it is something that you can answer even if you don't know or you have no previous experience about the pacemaker malfunction. But think a little. What is doing this spike? This spike is producing a QRS, and this is the purpose of the spike. But what we see here, a spike that is no producing QRS, another spike that is no producing QRS. This spike could, yes, produce a QRS, but this spike is no, this is no, this is yes. So what you see that a failure, the pacemaker is failing to produce QRS. And it is called, the term that use that is failure to capture failure. The pacemaker cannot capture the muscle of the heart producing the propagation of the electrical impulse, and for that reason, there is a failure. But you don't need to know so much. Okay, you just understanding that this spike is pacemaker, and the only option that is talking here about pacemaker, you must answer this question, even if you don't have enough knowledge or deep knowledge to know that it is a pacemaker failure. The only pacemaker that is mentioned here is option C. So there are some strategies that you can use when you don't have any idea what they are talking about. You can use those strategies. The best strategy is reading carefully the question and understanding what they want to be answered. Second strategy that is very important, rule out, okay, eliminate the options that you know subtly, really that are incorrect. Frequently, you have some knowledge that allows you to rule out some options. Then you increase your possibility of guessing. But in this case, the guessing is giving away, is regalado. So this is the only pacemaker there. You say, it is common in Nclex to have those giving away questions. Yes, a lot. Because also Nclex is exploring if you as a nurse has common sense. Because a nurse with common sense, even if has not the knowledge necessary, can be useful and safe for the client, because a nurse with common sense is a nurse that is going to detect that something wrong. I don't know what, but something wrong with the patient. I don't see this patient, okay, it's too pale, it's too sweaty, it's not good, it's behaving weird. I don't know what is happening with the client. I don't have the deep knowledge to know, but I have common sense, and my common sense say I need to call for somebody who can know what is happening. This is an example in which the Nclex is exploring your common sense. Okay, let's continue. No question about that. No, everybody can now identify a pacemaker when you see the spikes. Yes, this is what we can take home of this question. Move. The telemetry, you know what is telemetry, no? Telemetry is a service where maybe some of you never been in a telemetry service or don't understand what it is, where you have a lot of clients in their rooms, and each one of those clients has a monitor, a device that is transmitted tetherless, is transmitted through the air, wireless, okay? the cardiac rhythm, because they have in the chest stickers and a device that can register and emit featherless through the air and then somebody can be in a central station with many monitors, okay, many monitors observing, okay, somebody sitting here can be, okay, seeing what is happening in the client's room, only seeing what is happening with the cardiac rhythm. And this is called telemetry. Just in case you don't know what is telemetry, because it's important to understand what is telemetry for understanding those questions. The telemetry nurse is in a central console and observes the following image in one of the monitors. What should the nurse do next? And then you see the image. We already discussed that it's the flat line, no? And the flat line is called, how we call that? Asystole, yes? Asystole, asystole. So we don't see any QRS, any electrical activity, called that asystole. So we assume that if it is a true asystole, the heart is not beating. And if the heart is not beating, the client is not having cardiac output, the brain is not receiving blood, and it is an absolute emergency. What asystole implies need to be activated, the code that provides the clients the possibility of resuscitation. As far the client is do not resuscitate, DNR. And the resuscitation is going to include chest compression to keep the blood moving, and it's going to include the administration of medication to return the client to electrical activity. A detail, if it is a true asystole, electrical shock, defibrillation is not indicated. We don't give electrical shock, even what you saw in movies and in the TV. We don't administer electrical shock to clients with asystole. It's clear? What we do, we keep the client alive, pumping the blood mechanically with our arms. We're pumping of the chest compression. And as advanced cardiac life support, medications are administered to reestablish an electrical activity. The most common given medication is epinephrine, adrenaline, epinephrine, okay? Period. You don't need to go beyond that. The problem of the asystole is that sometimes the asystole is not true. It's not true. It's false. Why false? Because we have a client in telemetry, okay, a client in telemetry that has in the chest, okay, 5, okay, electrode stickers, okay, connected to cables, okay, to cables that go to a little device, okay, that is emitting, okay, their stuff, yeah. Why so many stickers? Because you have the options of making different derivations, are called. Derivation is no more than perspective to see physically, electrically, but physically the heart. So I mean, I can see something from this perspective, or I can be the other thing through the other perspective. So there are different possibilities to seeing the heart of this client, the heart of this client. So we have a derivation like D1, D2, D3, okay? And we have precordial derivations, etc. So there are different derivations. The derivations are made with combination of the cables, okay? So D1 is the right arm and left arm. Only these 2 cables makes D1, okay? D1, D2. D2 is between this and this, etc., etc. So sometimes the client has one cable that is loose or false, okay? And the cable falls. So if the cable that is falling is needed to see the derivation that in this moment the nurse is having in the monitor, then disappears the QRS. There is not register of the QRS complex, and you can see a flat line. So in this case, is not true. It's a fake asystole because the client is alive. The client is having cardiac rhythm. But the problem is that this cable fell and now the machine is not registering the activity. Sometimes it's true. Sometimes, okay, the patient has all the cable connected and then the patient is in asystole, so is dying. So for that reason, you need to determine if it's true or not true. You understand? So now that I had this explanation, what is the best answer? What is the best answer for this question?
D.
D.
D as in date, no?
Mm-hmm.
Yes.
Yes.
What time is going to take moving from the telemetry console to the client's room? 1 minute? Yes, 1 minute is possible. Yes. So we are losing 1 minute doing that. Do you think that is it possible to have in those options that are given in the question, okay, an option that could give you information sooner? I'm going to explain.
Yes. Obtain a different list.
Okay, so let's this is the idea. So let me go back so everybody understand. And if you have this question that is in English, having in English, you don't get, okay. So do you understand what I draw? That the client has 5 cables, okay, connected to the chest, okay. And for example, one derivation is this, using only these 2 cables. Yeah, but there are other cables, no? There are other cables, but the machine is getting for D1 only the information, okay, obtaining from these 2 cables. Yes, from these 2 cables. It's not using for D1 any of these 3 cables. Okay, and now I see I had the clients in D1 and I see a flat line. If I move the button of the machine to the derivation, for example, D2 or B1, yes, or B1, what happens? The machine starts using the other cables to see how is the rhythm of the client. So if in D1 I have this image, flat line, but in ABF I have again PQRS. What is my conclusion? That the cables needed for D1 fell and the patient have the other cables still connected. So it's not a true asystole, it's a fake asystole. And then I don't need to call a coach. I don't need to go running, okay, to the client's room. And I have only to go there with CAM to reposition to connect again the cable that is loose. You understand? Suppose that I move to D2, still flat line. ABF is still flat line. You say, oh no, it is a true asystole. Now you activate the code and everybody is going to this room to help the client. So it is a possibility. I'm not saying that it is the only scenario, but it is a possibility in this question. So suppose that in the the same question, I don't have in the question, I don't have this option, okay? Okay, so, and then I have, go and check for responsiveness and cable position. So now that I don't have, you need to understand that in English, the same question have a lot of variations, okay? I don't know if you were my student, sometimes I put you a quiz in the morning and I have the same class in the night. And sometimes I put the same question, but I change something in the question. And of course, the night group asked the morning group what you had in the quiz. And some of you committed the mistake of memorizing the right answer. But don't notice that when I change a little detail, now this is not anymore the right answer. Yes, I think that some of you, I hope that any of you, but some of you should remember that it happened to you. So you learn to not memorizing question, to understand that the topic could repeat, but not memorizing the answer, no? Because I need to understand. So it's, with nursing, it's not enough to memorize. I need to understand. So now I'm explaining you to understand. This is what is possibilities in case of asystole. Summarizing, in asystole, we have a problem. Could be true, could be fake. It does not happen. It does not happen in the other dysrhythmia. If you have, for example, this, it is true. If you have this, it is true. If you have any of this dysrhythmia, it is true. Why? Because this dysrhythmia cannot be mimicked, cannot be simulated by a loose cable, etc., etc. This dysrhythmia can be believed when you see them. But there is one dysrhythmia. There is one dysrhythmia. You understand me, no? You're paying attention to me, no? It's one dysrhythmia that could be fake, and it's the flat line, the asystole. Because can be two possibilities. Can be true, and the patient is dying and needs CPR and needs resuscitation, yes? Or can be false. False occurs when cables fall and you are at distance of the client because you are in a monitor at distance of the client, okay? And then you see a flat line. And then you say it could be true, could be false. Of course, the simple way of knowing that is going where the patient is and checking if the patient is alive. Sir, are you okay? And checking if the cable position. If the patient answers, yes, I'm okay, why you're hitting me? And then you say, oh, no, sorry, it's a cable that default. But if the patient is unresponsive and the cable is in position, of course, you say, oh my goodness, this is a real asystole, it's a real cardiac arrest. Until now, do you understand that, or you need me to explain that again?
Yes.
Nobody has problem with this understanding that the two possibilities.
No,
The question doesn't say specifically that he's responsive or not. So what do you do in that case?
Say again, if the patient...
The question doesn't specify if the patient is responsive or not.
Okay, that's why you need to find an alternative. In this option, you pay attention and you saw that I changed the question. Check for
yes.
This is one question, but the other question is the one that I gave you initially. That was in the Nclex. Okay, was in Nclex. Okay, they don't tell you the patient is responsive. No, you are sitting in a chair. You are sitting in a chair, seeing a monitor. Yes, seeing the monitor. You understand? And you see in the monitor the flat line. What you can do in this moment, okay, before going to check for responsiveness of the client, because you are at distance from the client. You understand me? And then there is one option. You take the button and you change this monitor that it has a flat line from D1, for example, that was pre-filled, to D2 or D3. So what can happen? That in all flat line, it is a true flat line, cold blue, and run there. Just other option. When you change the button, appears QRS, PQRS. Oh, this is the cable of the one that fell, and then the other derivations are working. So I don't need to call the code when I need to go there, calm, and reconnect the cable. Now you understood. Thank you. This is what I want. Ask question. Ask for clarification. And when somebody asks for a clarification, probably there is somebody else that is benefiting from this clarification. Thank you. Okay, so now
Professor,
everybody...
I have another question.
Sure, go ahead.
I'm sorry. Is auscultating the client's heart sound, is that going to take too long?
Have you heard this in the protocol of CPR?
No,
have you ever heard in the CPR class auscultation of heart sounds? Never. Carotid pulse. Carotid pulse is the only that you are going to be allowed to do to determine if there is cardiac contraction or not, carotid pulse. So
if we have it in the options, can we choose that?
you can rule out that. I can rule out auscultating the client's heart sound. I can rule out.
No, I mean, if we have carotid pulse, go for that?
Wait. Yes, if you have carotid pulse, could be an option. But okay, let me think. It's not this scenario. In this scenario, before going to the client to check the carotid pulse, you can know if the client is really or not in asystole. If the client is in real asystole, you can bet that has no carotid pulse. There are two, you need to memorize, there are two dysrhythmia that necessarily cannot have carotid pulse, mandatorily. One is real asystole. Real, true asystole, and second, ventricular fibrillation. Neither ventricular fibrillation nor asystole can have carotid pulse, okay? The VTAC is possible, and the other usually yes. But in this case, carotid pulse could be an option, but I don't think it's going to be, because in reality is like a second step, because before checking for carotid pulse, you check for responsiveness. Do you remember the CPR class? First is, sir, are you okay? No responsiveness, call second step, call the code. It is important. It's important we discuss that because it's another question in Nclex. In which order we do CPR? First, check the client. Check the client. And check the client need to be very fast. Because I don't know if you have ever tried to find the carotid pulse of other person, but it's not sometimes easy. Is not rapid. Some of you look in the wrong place. Check for responsiveness. Basically, okay, they recommend taking the knuckle and rub the sternum. It is very painful. And any person that is not, in arrest usually have some reaction when you feel this level of pain, like hypoglycemia, etc. So the CPR say first check for responsiveness. And then if there is no responsiveness independently of having or not carotid pulse, you need to call for help. The second step after checking the client, okay, that could be, check for responsiveness, check the cable, check the monitor, etc. Before checking the carotid pulse, we call for help. We cannot lose time going before asking for help. If we notice a person is unresponsive with pulse or Z-pulse, we immediately need to call for help. We need to call the code. It is the protocol of CPR. And trying to remember the class, trying to remember the video of the American Heart Association. Then after you call for help is when you are going to check carotid pulse. This is the third step, carotid pulse. And if there is no carotid pulse, meanwhile, the help comes, you are going to do chest compression. This is the sequence. First, check for responsiveness. Unresponsive, ask for help. Okay, and then if help in the hospital is to call the code. In the street is called 911 or other person. Then is when we check. So the checking carotid pulse is the third step in the CPR sequence. Please pay attention to that. Is testing in Nclex. And note that never is included in the assessment, in the focus assessment of a client that could be dying in cardiac arrest, is included auscultating for heart sounds or any other sound auscultation. So no, I could immediately rule out this option because it's not part of the protocol, okay? And we can rule out defibrillate because you know that defibrillation is not used that, okay? And then obviously administer epinephrine and atropine is something that is done as an advanced cardiac support after all those steps have been covered, because before giving epinephrine and atropine, the patient should have chest compression to keep the patient alive and call for help. So summarizing, the questions in Nclex are not tricky, are straightforward, but require your knowledge, your solid knowledge. Because, for example, they can ask you after checking for cables and responsiveness, what you do next. and verifying that it's a true AC2. Are you doing? And the answer is call the code, because the other option is going to check for carotid. If you select check for carotid before asking for help, you have the answer, the question wrong. You lost the question. And it's a question that could mean the death of the client. In Nclex, when you do commit a mistake that could imply the death of the client, it is going to be a very heavy question that subtracts points from you. You understand? Because let's talk in our language from that I talk. You kill the patient. You practically kill the patient. Because when you fail to ask for help, you are losing values in seconds that could make the difference between resuscitation or failure to resuscitate. It's clear. Okay, so don't forget, thanks for your question, that this is the sequence. It's important. If I put in a question, okay, check carotid pulse, you need, and this is the answer, you need already to check for responsiveness and to status of the client, but in very superficial way, okay? Already call for help, and then where you check for carotid pulse. Which one is the purpose of checking for carotid pulse? Deciding if you start chest compression or not. There are some time of these arrhythmias that requires the protocol of cardiac arrest. And maybe, very rare, but maybe the client has pulse. Okay, in this case, there is no need of chest compression. But this is the person checking for carotid pulse to determine if you don't feel carotid pulse in a very rapid evaluation, then you need to start chest compression, because you need to keep the client alive, moving the blood to the brain. Meanwhile, the help and the advanced cardio life support arrive, and the defibrillator arrive if this is ventricular fibrillation, which is the most common. So summarizing, talking back in asystole is the most tricky situation in cardiac arrest, because could be true, could be false. Are we good? Another example, the nurse observes the following image in the client's monitor, and you see this image. What should the nurse prepare to do next? This is another option where you apply the previous concept. Okay, what we see here, we see a very rapid rhythm, yeah? So it's a rhythm that we can believe. It is not a flat line. It's a rhythm that you can believe, okay? And you know that this rhythm is a tachycardia because it's very rapid. So it could be two types of tachycardia, supraventricular or ventricular. For test purposes, for Nclex purposes, this tachycardia could be either supra or ventricular. And we know the difference of supra versus ventricular, the QRS width. If the QRS is narrow, is thin, is supra. If the QRS is wide, tends to be ventricular. For the nursing level and Nclex level, usually this is enough to know. So obviously it is a very wide QRS. It's a very wide QRS. You see that? It's a very wide QRS. So you diagnose then that it is a ventricular tachycardia. I mean, always the ventricular tachycardia are similar to the picket fence that I had in the back of my backyard. Okay?
Professor, I'm sorry to interrupt you. I just lost a little bit of connection when you were saying if it is wide, it is supraventricular.
Remember that the rhythm that are coming from the atrium, yes, atrium, right atrium, left atrium, yes, and right ventricle, left ventricle, yes. The rhythm that are coming from the atriums are narrow. Okay, so when you see, for example, an atrium, no? Atrium, no? Fibrillation, how is the QRS? Huh? Narrow. Yeah?
Oh,
You see that? It's narrow, you know?
Thank you.
But when you see a wide QRS, like this one, you say, oh, probably it's coming from the ventricle. Yes. So wide QRS, ventricular. Narrow QRS, supraventricular. This is the basic law. All the rules have exceptions that confirm the rule. we can work with the rule. We don't need to know the exception. We leave the exception for the cardiologist, okay, or the specialist. So for Nclex purposes, it is a good rule that we can keep. It's a good rule that we can keep. So what I see first, it is a tachycardia. And then how are the QRS? Very wide. You can compare the width of this QRS with the width of this QRS, and you notice the difference. Este es un flaco y este es un gordo. Yes, you see the difference. Yes, and it's rapid. So it is rapid and regular, and is wide. I say VTAC, ventricular tachycardia. Okay. In relation with the ventricular tachycardia, you need to understand that is a potentially catastrophic and lethal rhythm. That the big majority, more than 90% of clients in VTAC have no pulse, so no cardiac output, so no movement of blood, no blood going to the brain, and the patient can die in the next 3 to 5 minutes. Is a minority of clients with ventricular tachycardia at the beginning, they can have pulse. But then if it is not solved, they are going quickly to deteriorate, and then they are going to lose the pulse. They are going to lose the cardiac output. So all the VTAC, once are identified in the monitor, are treated the same with a code and defibrillation. The treatment of the VTAC basically is defibrillation. There are alternatives, but are doctor decisions, okay? Doctor decision. So by protocol, the most common treatment of the ventricular tachycardia is defibrillation. So either ventricular fibrillation or VTACs are defibrillated. I mean electrical shock without synchronization, okay? So what you identify here, a VTAC. This is a ventricular tachycardia. It's a ventricular tachycardia. Okay, so now the question say, you identify this rhythm as a ventricular tachycardia, okay? Sorry, messing here. What do you do next? What means do next? Is a prioritization, a chronological prioritization. It's the same as what you do first. So what do you think is going to be the next to do when you see this image in the monitor? What you do? Call for help. You are right. And any other answer will imply the decreased possibilities of recovering this client. If you pretend to solve this rhythm alone without help and without all the resources that are needed, okay, including the defibrillator, then you are killing the client. If you think that you can solve this case alone, then you kill the client. If you think that giving chest compression, giving medication, or doing you alone an electrical shock, you're killing the client. What the protocol wants you is that don't work alone in these cases. So the next that you need to do is call for help. And it has been taught to you in your CPR class, and you can translate, because CPR is when you are outside the hospital, no? The CPR class is when you are outside the hospital. So now you can translate that to the hospital scenario. So you need to know, this is the rule. Any rule has exception, it's true. You can find there, if you are witnessing the beginning of the dysrhythmia, can you take the decision by yourself if you are a nurse, a specialist in ICU, to do a defibrillation? Okay, those are the exceptions of the rule that are very rare, are practically impossible. Remember that your test is entry-level generalist nursing. Is not ICU nursing. So don't complicate the situation. Follow the basic protocols of an non-experienced nurse saying, and the only person that is saying in the monitor, this VTAC, and then what you do first, call for help. Call for help. And now, once that you call for help, is when you go to check if the client has carotid pulse. If the client has carotid pulse, you don't give chest compression. If the client has not carotid pulse, just start chest compression, period, and wait until the help arrives. When the help arrives, it starts the advanced cardiac support that is not tested in Nclex. Advanced cardiac support is not going for Nclex. What you need to know in Nclex is basic life support, BLS. Okay, so it is what goes for the Nclex. Okay. I know that you are going to have some practice questions that confuse you, that if you are witnessing that, forget it. It is not the important situation. This is an ICU nurse that is witnessing a beginning of a ventricular fibrillation, something like this. The basic is recognize the problem, call for help, give chest compression if the client has not a cardiac output, and wait for the help, and anticipate that it is a ventricular dysrhythmia, like the B-tachycardia ventricular fibrillation. The patient will receive an electrical shock. And if the patient is in asystole, will not receive electrical shock, period. Don't complicate. Are we good? Can we move? Okay. Let's see this question. Let's get out of this EKGs and cardiovascular stuff that are so frequent in English. Let's see this question. The neonate unit nurse sees the following marks in the newborn skin. It's the skin of a newborn. As you notice, has many like freckles and a big mole there, no? Birthmark. How you document this finding in this mark, this such abundant, okay, marks in the documentation? Who heard about this? The Guito, what means café du lait? Café au lait. Café au lait. What means café au lait? Huh?
That's French. That's coffee with milk.
Yes.
Café au lait.
Café con leche.
This is a neurofibromatosis disease.
Yes.
Neurofibromatosis disease.
So sometimes Nclex, okay, ask you questions that are a little specialized. And you need to know of the newborns what is not expected, what is abnormal. No? So these marks are not usual. So many, no? So many. You notice that too many, okay, are not usual in a newborn. When they are present, the nurse should suspect that this child has a hereditary disease called neurofibromatosis. Okay, neuro as nerve.
First of all, that's not for me.
Fibromatosis. Okay. This is called neurofibromatosis. Is genetic, is hereditary, and can be born. And the way of noticing that is the coffee and milk, or café au lait. Okay, café au lait.
I saw a client once with that, and
Yes.
then I was so because I'm not a nurse, so I was just as a volunteer, and it's so interesting because then I try to learn about it, and it can be inherited, but you can have it later on. It has like 3
It
different
can be
stages.
a new mutation, can be a first time a new mutation.
Yeah, and it was so sad because he was very young. He was 37 years old, and he was dying basically. Yeah.
Yeah, you're right. There are different severities. There are very mild forms. So the penetrance of the genetic problem is variable. So our very mild cases are very severe cases. But then a part of these spots in the skin that is no big deal, they develop tumors in the body that originates in the nerve, in the peripheral nerve.
And they're painful. They're very painful.
And depending on the location, the tumors can be painful or not, but then the tumors include the brain and other parts of the body that could kill the client, could kill the client.
And it was for the first time that I was able to hear crackles for the first time, like really clear.
Okay, nice, no? And you learn from France, finally you understand what is this crack.
Yeah, I was just a volunteer and I learned all of that one.
Okay, that's why I said the day that you get this license and just start working, and then this is when you really will start learning nursing. Because what teaches you nursing is not a professor, is not a book. is the combination of the client, which is 95%, plus the book and the professors. You know, is the client what teach you, okay, nursing. And I think that you agree with me after what you commented. Okay, so just in.
Come on, give yourself some credit. You know you're good.
Okay, well, give me 5% and I'm satisfied. Okay, so this is a disease that could be seen in newborn, and the role of the nurse is, if you see that, report that, because you cannot do anything else. Report that and suspect that those are, as you see, coffee and milk. You don't need to read that to write that in French because it's a café au lait. Okay, so at least if you go to France and you want to ask for a café con leche, you know how to say that. Okay, de mi tazo café au lait. Okay. In which of the following 4 cases the nurse anticipates that a multidisciplinary team must be best manage the client? Interesting. There are some diseases or some cases that can be managed by 1 or 2 persons, the doctors and the nurse, or only the doctors, or only the nurse, and is enough. But there are some cases that are much more complex that require the participation of many members of the multidisciplinary teams. The multidisciplinary teams include the providers, that are doctors, nurse practitioners, and physician assistants, the nurses, that includes registered nurse, LPNs and CNAs, or UAPs, includes the dietary specialist, includes the social worker, includes the physical therapist, the occupational therapist, and many, many other people. Yes, specialists, different specialists, okay, respiratory therapists, etc. This is a multidisciplinary team. Remember that you need to be interacting with that. You as an RN has the scope of the asking for consultation of members of the team, to carry out for consultations, suggest consultations, or do consultation depending on the policies of each facility. And remember, you communicate with those members of the team. So a registered nurse can speak the language of the dietitian, can speak the language of a doctor, can speak the language of physical therapist, etc., etc., etc. That's why nursing is so demanding. And that's why I've been telling so many times, hey, the problem is nursing is too difficult, you know, because you need to be able to manage all those specialties, to interact with all those specialties. And they ask you, in which of these 4 clients you think a multidisciplinary team, so a complex team, could participate? And then you have a client with atrial fibrillation, a client with sickle cell disease, a client with cystic fibrosis, and a client with lymphoma, cancer in the lymph node. So let's analyze, okay, all those seem to require a lot of attention. A client with atrial fibrillation, so basically who is participating here? The cardiologist, okay, the cardiologist, which is that can, you know, manage that the best, and the nurse that is giving the medication that we mentioned before. The client with sickle cell disease, so here is participating the hematologist and the nurse that are carrying out the order. Let me jump to Hodgkin lymphoma. It's a cancer. So you're going to have an oncologist and an oncologist nurse administer the oncological therapy. And then you have the patient with cystic fibrosis. So what we know about cystic fibrosis is a genetic disease. So it requires the geneticist, no? And is a disease that affects the lungs. So requires the participation of the pulmonologist and the respiratory therapist. And is a disease that affects the exocrine pancreas, yes? So requires the participation because the exocrine pancreatic insufficiency of the gastroenterologist and the dietitian, and of course the nurse. So now, which one is the answer? Cystic fibrosis, obviously. So this is the way that you are going to analyze based in your knowledge of that, okay? In your knowledge of that. Do you remember cystic fibrosis? That is autosomic recessive. That both parents need to be carriers of the disease, but usually they are healthy because they are heterozygous. They don't only carry one gene affected. But when they make babies, okay, each time they make a baby, then they have a 25%, 1 in 4 possibility of combining their two, damaged genes, and then one baby can be homozygous for the trait, and then is going to suffer the disease. And the secretions are going to be very thick, and is going to damage the lungs, producing a chronic lung disease and chronic hypoxia and recurrent pulmonary infections. Okay, what characteristic have the fingers of those kids? Who knows?
They also have clubbing nails, right?
Clothing, and this is Nclex question. Clothing.
Profe, and the nutrition.
And then the other part is the exocrine pancreas. You know, the pancreas is an organ that have endocrine and exocrine. Yes, and the endocrine is insulin, etc. But the exocrine is the production of the pancreatic juice that digests the food that we eat. And now comes the topic of nutrition. No? But then the problem of nutrition or malnutrition is related with the failure of the exocrine pancreas to produce the pancreatic juice able to digest the food. So now the food is not digested. And because the food is not digested, we have maldigestion. And of the 3 macronutrients, carbohydrate, proteins, and fats, the most difficult to digest are the fats. Yes? And for that reason, it's going to be a lot of fat in the poo-poo. And we call that steatorrhea. Steatorrhea, when there is fat in the poo-poo. And the presence of a steatorrhea means that the food is not digested. And if the food is not digested, cannot be absorbed, cannot be, used by the individual. And don't forget that there are 4 vitamins that are very important: A, D, K, E, that are fat soluble. And if the fats are not absorbed, those vitamins are not absorbed. So now your nutrition problem. You have a child, because it's hereditary, a child with malnutrition, with failure to thrive, failure to gain weight and to grow, and with vitamins deficiencies, no? And then you have a nutritional problem. That's why the dietitian and the gastroenterologist need to participate in that. That's why I said that the gastroenterologist and the dietitian need to participate, because there is a nutrition problem secondary to the malabsorption and the maldigestion and malabsorption, yes, and the steatorrhea. And this is what you need to know, trying to apply this knowledge that I know you read, I know you at least you had to listen in the lecture this topic. Try to apply this to a question, and don't forget that also the lungs have this problem. Okay, that's it. Another question that I have many questions and like randomly selected question to initiate today this activity. Which one is the mechanism of action of Acarbose? Acarbose is a medication that we should study in pharmacology and in diabetes. Is a medication for diabetes mellitus, okay? And it's not well known. It's not commonly used. It's not well known, but it's in Nclex. So Acarbose is, you need to know that when you eat bread, a bun, you're eating starch. Starch is a huge molecule. It's a huge molecule that has many molecules inside. The starch is the combination of many molecules of glucose. So this huge molecule that is eating in your mouth goes to your stomach and intestine, and then certain enzymes, mainly the amylase, are going to break down this starch into glucose. And then the glucose is the molecule that you can absorb. You can pass from the lumen of your intestine to your blood, and now the glucose is going to be in your blood. Yes? Okay. This is the digestion of the carbohydrate, the starch. See, so the glucose that a diabetic client is having in his or her blood is coming from the digestion of those carbohydrates. So there is a possibility of inhibiting those enzymes that digest the carbohydrate. If we inhibit those enzymes, then the carbohydrate, the complex carbohydrate, like for example, the starch, the lactose of the milk, the fructose of the fruit, the saccharose of the sugar cane, okay, is going to be not digested. It's not going to be transformed in glucose, so cannot pass to the blood. So what is the consequence of taking Acarbose is that the client is not absorbing so much glucose because all the glucose is not produced, all the carbohydrates are not digested. So on purpose, this medication is producing a maldigestion and malabsorption of the carbohydrates. Okay, so delay, okay, the intestinal digestion of the polysaccharides. Polysaccharides is another name that we give to the sugars, okay? Polysaccharides is the other name of the sugars, okay? So is working locally in the intestine, the Acarbose, partially inhibiting, not totally, the digestion of the sugars, of the polysaccharides, this digestion that grossly I mentioned before. Who can tell me could be this is the mechanism of action and the desired outcome? It helps to reduce the blood sugar. So now based in this explanation, who can tell me in which moment you need as a nurse to administer the tablet of Acarbose?
Before meals?
With food?
Immediately before meals or with the meal. Okay, if you say before meals, you say immediately. Use the word immediately before meals. Or also could be with the meal. So the idea is that when you eat the polysaccharide or the carbohydrate, then you are also consuming the medication that will inhibit those enzymes that you just have in the intestine to digest those carbohydrates. Yes. So with the meals, this is one question. If you give that every 8 hours, but in moment of fasting, it is not going to work. You understand? Second question. By the way, in Nclex, when you study pharmacology, any medication, you need to know two details. First, which one is the purpose of giving the medication? So now we know the purpose. The purpose is to inhibit the digestion of the sugars. And this way, the sugars are not going to be absorbed in its totality. And as a consequence, the blood sugar will drop, will decrease. Are we good, no? So now we have the mechanism of action, and the implication of the mechanism of action need to be given with the meals. Now, the second question that you are going to ask yourself, and is going to be asked to you in pharmacologist questions in English. Which side effect, which undesired
Flatulence.
effect, yes,
It is
with undesired effects this medication can bring. So if you are talking about an gentamicin or streptomycin, which is the desired action, kills the bacteria. So treat an infection. Which one is the side effect? Ototoxic, nephrotoxic. Yes. Now we are talking about Acarbose. So which one is the only side effect? First, you can have too low blood sugar. You can have a hypoglycemia, especially if it is combined with other hypoglycemic medication. Because any medication that is intended to lower the blood sugar, as a possibility, you need to include the possibility of hypoglycemia, because hypoglycemia is very bad. It's a priority. It's an emergency. And of course, the potential of acarbose to produce hypoglycemia is low compared with insulin and sulfonylureas. There are medications that have very potent capacity, they have very strong capacity of producing hypoglycemia. Insulin and sulfonylureas, those glipizide, glimepiride, glyburide, etc., yes, the GLI or Y, yeah, those are the most potent. Remember, there are other medications for blood sugar like metformin that have very low potential producing, okay, hypoglycemia. Pioglitazone acts as very low potential producing low blood sugar. It is acarbose, very low potential, but it's a potential. But then, if you are not digesting the sugar, who are going to have a party in your intestine? The bacteria, your biome, your normal flora. Oh, look, a party, a lot of food here, let's eat. And of course, when they digest these carbohydrates, they are not digested by you, in the colons are going to produce one, flatulence. Okay, you are, very musical, very musical. But then the other one is diarrhea. Yes, so diarrhea and flatulence are the side effects. So now we study acarbose. Okay, can you remember this? It's carbohydrate. A is no carbohydrate. Yes, no carbohydrate. Okay, so there's a name in